Hello. This video is essentially to explain what is intraoperative cholangiogram in gallbladder removal surgery, why we do it, and what can be some problems with it um, when we are doing it. Just a brief overview of anatomy. You can see gallbladder here, and this is basically attached to this structure, what we call the common bile duct. Liver makes a lot of bile, and this goes down from the left and right of liver, as you can see, to the common bile duct, and a lot of bile gets stored in the gallbladder, and from there it goes into the main duct, what we call the common bile duct. Normally this structure is around 6 millimeter in size, um, and it goes through the pancreas. You can see pancreas here, and then it goes into this part of the small bowel we call duodenum. Stomach is in this area. Uh, so this is another view. It shows how the bile ducts look inside the liver, and they branch like a tree. And on the outside, they form a common duct. Gallbladder is attached to one side, and the connection of the bile duct and the gallbladder is through a tube called cystic duct. This is the area which we will be interested in when we are doing a cholangiogram. I'll leave these two slides for now and directly go to how we do a cholangiogram. So if we are doing surgery laparoscopically or open, our objective is to delineate anatomy. This is because if we don't know where the important structures are, we may end up damaging them or injuring them. So what we do is we essentially lift. This is an intraoperative view. Gallbladder is lifted towards the right shoulder of the patient. So right shoulder would be somewhere here, and you can see the surgeon is trying to delineate the anatomy here by retracting the gallbladder and demonstrating the junction of the gallbladder to the bile duct via cystic duct. This is important, and no gallbladder surgery or cholecystectomy should be done without establishing clear anatomical boundaries. You can see here the gallbladder is attached to the bile duct via cystic duct and a small artery which normally comes off the right hepatic artery or right branch of the hepatic artery, which is here, which is the main artery that goes into the liver. It divides into right and left branches. Most of the time gallbladder blood supply is coming from that artery. So these two arteries are this artery is seen here clearly. Once this view has been established, this is called critical view of safety. The surgeon will then clip the cystic duct, which you can see here, and also the artery. I normally use a clip. I don't use hemolock, and then the gallbladder is removed. Basically, we cut it somewhere here and put it in a bag and take it out. Now, what is cholangiogram? Cholangiogram is a small plastic catheter which goes into the cystic duct, and we leave it somewhere here. And then what we do is we give contrast. So contrast, normally what we use is omnipaque. Now, omnipaque is radio opaque, which essentially means is that the X-rays will not be able to pass through it. So when the contrast goes into this tube and fills it up, and we take X-rays, then there will be two advantages of it. One, we will be able to see where the bile duct is, so we will be able to get the anatomy or delineate the anatomy. So that's our first objective. The second objective is we will be able to see if there is any pathology in the bile duct, such as stones or stricture. Stricture is narrowing of the bile duct. So this is one intraoperative view where surgeon has introduced the catheter, and this is the long instrument which is holding the catheter in place. Contrast is injected, and you can see the bile duct, the branching inside the liver here. This is the main bile duct. This is the cystic duct which has been divided here, and the bile duct which normally tapers off as it goes down is seen very nicely. This is a normal image, and then here you can see all the contrast going into the small bowel or the duodenum. This is what we want to see when we are doing the operation. Now, if we are unsure where the bile duct is and we are worried that we might have injured the bile duct, then we may do a cholangiogram to make sure that there is no missed injury. The sooner we identify the injury, if there is injury, the better it is. Secondly, if there is a pathology in the bile duct. So pathology, in most of the cases, is blockage due to stone. So you can see here, the contrast is not going down into the duodenum. And you can also see these light spots here. This is what we call filling defects, and these are because of stones. So you can see an abrupt cut off here, no contrast going into the duodenum, and some stones there. And you can also see bile duct is quite dilated. You can see the small cystic duct area. The important thing here is to understand that when we are doing cholangiogram, it gives us good information about the anatomy. It tells us about the pathology of if there is any problem with the bile duct. When we give the cholangiogram, there are few problems. One, it involves exposure to X-rays or radiations. Two, it causes a lot of well, what it does is that uh, uh, we have to inject the contrast under a lot of pressure into the common bile duct. So this leads to increased hydrostatic pressure within the biliary system, which essentially is that we are creating a lot of high pressure into the biliary system and into the liver as well. The third thing is that the contrast itself may cause, in some patients, allergic reactions and some sort of, what I would basically say to my patients, transient liver injury. Omnipaque is not supposed to go into the liver. So when we inject something in the biliary system uh, with increased pressure, which we create within the biliary system, and when we inject contrast, this can have some detrimental effect on the liver. Now, it is important that we know how the quality of the liver is. Nowadays, because of reasons which are beyond the scope of this short video, liver can be diseased, or many patients have got fatty liver. Patients might be obese, they have metabolic syndrome such as diabetes. So the liver may not have good reserves within, and if we see intraoperatively the liver looks a bit unhealthy and it looks fatty, then I start to avoid doing a cholangiogram if I can, or if I have to do it, I dilute the contrast. Therefore, it's also important then in private sector or even in NHS, when we are asking patients to prepare themselves for cholecystectomy, we routinely ask them to use the liver shrinkage diet, which essentially is a fat-free diet to improve the health of the liver, so that if there is a complication or if we are doing the cholangiogram, then we can potentially do more and there is less of a liver injury. I had a few patients where I had to do a cholangiogram. They had background fatty liver disease, and post-operatively they were feeling more sick and nauseous, and some of them stayed in hospital for a day or two just because their liver health was not good. So it is important that liver shrinkage diet is followed. If we are forced to do a cholangiogram because of reasons, technical reasons, then we do it. But I tend to avoid it if I can, if patient has got some background fatty liver disease. Hope this clarifies few things. Thank you. And if you've got any questions, please feel free to email me. I'm sorry this is quite rushed, but I hope this is useful. Thank you.